It's like I was saying, I'm a very visual person, and this is a very hard concept, and I feel like teaching it through a PowerPoint is not helpful at all. And so doing it this way, actually, I learned how to do it kind of this way years ago, and I've just been adapting it and changing it as I teach it throughout the years. But it seems like it's a great way for y'all to grasp the material. So, all right, action, are we good? All right, fabulous. So now let's move into our thyroid crises, all right? So our next key playing factor in our pituitary, our anterior pituitary, is our TSH. Our TSH goes to our thyroid and tells our thyroid to either, work better, work harder, work slower. If you remember back to 113, you talked about hypothyroidism and hyperthyroidism. Does anybody here have thyroid issues? We're kindred spirits, aren't we? Yeah, thyroid sucks. I had thyroid cancer back probably 6 years ago, and had to have part of it removed because they thought it was just a gland or nodule issue, and then it came back cancerous, so then they had to go back in and remove the rest of it, and then I had to have radioactive iodine 6 months later. And I get to go see the lovely people at the City of Hope Cancer Center in Noonan. I go about every 3 months because my levels were iffy a couple years ago, so now they just keep monitoring it over and over and over again. If you ever have cancer, anybody in your family has cancer, City of Hope, just a plug for them. They're like the Chick-fil-A of hospitals. You know how amazing like Chick-fil-A is? Even if you don't like the food, the service is spectacular, okay? City of Hope is the Chick-fil-A of all hospitals. If you're ever into oncology, it's a great place to go work too. Like, they're wonderful there. I love them. I go all the time, so they're fantastic. But when they took my thyroid out, I wound up having hypothyroidism, which blows buckets. It's awful, okay? So remember back to hypo and hyperthyroidism back from 113. Somebody with hypothyroidism, they have cold intolerance, they're sleepy, everything moves slowly, so like GI issues, usually constipation is a problem, everything's moving slow, and they're sluggish, and they gain weight. I would say that's why I stay pleasantly plump, because I have no thyroid, no matter what I do. But really, I probably should get off my butt and do something, but anyways. So with hypothyroidism, one big extreme that you can do is myxedema coma. So this happens to patients who have hypothyroidism. So think about everything that happens with hypothyroidism. It's literally multiplied by 100. So they are extremely cold. This is really like a life-threatening condition. So hypothyroidism, remember with your hypothyroidism, they have an elevated in their TSH and the decrease in their T3 and T4. I got pretty close to a myxedema coma whenever I was getting ready for radioactive iodine, because I had to be off my thyroid medicine. They wanted my TSH to get up to like 25, anywhere between 25 and 45. Well, I was off my thyroid medicine for 2 weeks. It was during Children's Expo time too, of all times to have it. And it was in October, during Children's Expo time. And it was hot outside. I mean, in Alabama, it don't get cold till like February or something. But I was in my office with like a jacket, my heater on, I had a heating pad on, my head was killing me. I was very sluggish, very fatigued. Like, I would get up in the morning, barely have enough energy to get myself ready to come to work and to go home. And as soon as I get home, I would crash. Luckily, I just sold my house and we moved in with my grandmother, the house that I inherited this time. Thankfully, we moved in with her, and her and my mom were very helpful, because I had just gotten a divorce too. So I got a divorce, got diagnosed with thyroid cancer, and then had to go through all the lovely hypothyroidism issues. But when they took away my levothyroxine, levothyroxine is how a patient with hypothyroidism lives. They have to have that because it's like you've got to have that in order for your body to function. Well, they took it away for 2 weeks, and then I couldn't have anything with iodine in it. If you ever tried to have a low iodine diet, just when you're bored one day, look it up. It's terrible. I'm a coffee drinker. I like coffee in the morning. But in my coffee, I like milk. You can't have any dairy. Dairy apparently is really high in iodine. Didn't know that. One thing I found that I could have was Oreos. Isn't that crazy? Oreos, but I couldn't have no doggone milk. So like, what's the point? You can't duck. Like, this just wasn't working. And I could have those little Pillsbury croissant things. I could have those, and I could have Prego spaghetti sauce. Had the lowest amount of iodine, which was really strange. But you can eat all the fruits and vegetables you wanted. Raw fruits and vegetables. No, that just didn't sound pleasant. And all the lean meats that you could eat, however, you couldn't season them. Like, there was no seasoning, no nothing. Anyway, long story short, being off of my thyroid medicine for 2 weeks, my TSH got up to 145, which was outrageously high. Outrageously high. How I didn't die, I don't even know. I feel like that should be something that's illegal to do. But I was miserable. I was very close to a myxedema coma. Like, if I could think about what that feels like on my worst day with hypothyroidism, it's 10 times worse for these patients. Like, everything is slow. It is very life-threatening because not only can their heart rate decrease to where it goes to 0, their respiratory rate can also decrease. Their temperature decreases. What do you think happens to their blood pressure?
Tanks.
It tanks. Everything tanks. Everything just goes down. So everything. I mean, their temperature, their blood pressure, their heart rate, everything tanks. Everything. Everything just gets slow and low to where almost it stops. Think about a coma patient. I know y'all talk about coma patients with ICU patients, right? Mm-hmm. Most of them have to be ventilated. Same thing with your myxedema coma patients. That's kind of where they're headed towards. These patients are also very drowsy. They might wind up needing a mechanical ventilator to ventilate for them because their respiratory rate also decreases to where it's almost nothing. So everything decreases. This can happen in patients who, primarily your female patients. Thyroid issues can affect both sexes, but it primarily does affect women more than it does men. It can happen from certain triggers such as stress or anxiety, illness. Those are the more common triggers that can cause a myxedema coma. This can also happen with that psychotic drug we talked about earlier, which is lithium, that can cause diabetes insipidus. Lithium can also lead to myxedema coma. And this also happens to patients who don't take their meds. If you don't take your thyroid meds, that's what's going to happen to you. It is a gradual process, okay? It is not instant. It is gradual. It is not instantaneous. So how do you think we fix it?
Take your medicine.
Take your medicine. I like it. They need their medicine. They need their thyroid medicine, their levothyroxine. In an acute thing such as myxedema coma, usually the first line treatment is IV levothyroxine. I never even knew that they made IV levothyroxine until I started researching this a couple years ago. I just knew it was a pill you took every day. Like, I thought that's the only way it came. You know, certain meds only come certain ways. I didn't know that you could actually get IV levothyroxine. I thought that's pretty interesting. But someone with a myxedema coma, they need that levothyroxine pretty quickly. If you remember talking about hypothyroidism, it can take up to 5 to 7 days for levothyroxine to actually get in a good balance in your body. The IV levothyroxine does not take that long. It actually works pretty quickly. One thing to remember as nursing considerations, would these patients be good candidates to get something like a sedative? Mm-hmm. No. Because what do sedatives do? Slow everything down. If I'm already slow to a stop, I don't need anything that's slowing me down even more. So nursing interventions or considerations with these patients, make sure that we don't give them anything that's sedative-wise. They also have a very big cold intolerance. Like, they are freezing cold. So warming blankets, a bear hugger. They're going to be in the ICU, so monitoring their EKG. I worry about bradycardia. What do I do for bradycardia?
Atropine.
Atropine. Atropine speeds conduction from your SA node to your AV node. That's what makes your rate go up. So I'm monitoring my EKG. Atropine can be used for bradycardia. I'm also keeping an eye on my electrolytes, because if everything is moving slow, am I getting rid of things throughout my body? No, not really. I want to holding on to stuff. I can actually be overhydrated, which is going to do what to my sodium levels? Decrease them. All right, next is your thyroid storm. This is the complete opposite. This has to do with patients who have hyperthyroidism. So they have a low TSH and a high T3, T4. Now, what do patients with hyperthyroidism look like? Skinny. What else? Very hyperactive. Remember, hyper means shrink, skinny. So hyperactive, thin, everything's running constantly. What happens to their heart rate?
Tachycardia.
They're tachycardic. So this is an extreme in a patient who has hyperthyroidism. So everything that's moving fast, it just gets even faster. All right, most oftentimes, this is also considered a life-threatening situation. It can affect people with hyperthyroidism. It oftentimes happens during thyroid surgery. It can also be triggered by stress or illness, just like myxedema coma can be triggered by stress or illness. Most oftentimes, what happens thyroid storm-wise is this happens when they're trying to remove the thyroid tissue. When they remove the thyroid tissue, what do they leave behind? They're supposed to leave behind this parathyroid gland. Sometimes that happens, sometimes it doesn't. But it can send signals to your body to be like, hey, you know, it starts fighting back, basically, is what happens when they're trying to remove your thyroid. Your body starts fighting back. That T3, T4 starts going crazy and really fighting back, and it causes you to have what they call a thyroid storm. The main thing with a thyroid storm is the tachycardia. Tachycardia into like SVT tachycardia. So a heart rate into the 300s. Am I perfusing with a heart rate that high? No. Just because it's moving faster does not mean that I'm getting blood circulated better. So tachycardia means that I'm having poor cardiac output. Your heart can only do that for so long until it gives out. Now, what's treatment for SVT? Adenosine. You know the dosage? 6, then 12. Used to be 3 doses. We used to do 6, 12, and 12. Now it's just 6 and 12. What's the fun thing about adenosine? How fast do you push it? You slam it as fast as you can possibly give it. Adenosine can be used to treat a side effect if your patient does develop SVT. But they will also have an elevation in their temperature, so they can get a fever. Fever is not caused from illness or infection. It's caused from all the inflammation and stuff that's going on in the body. It's caused from the storm that's happening inside your whole body. So we've got to get their temperature down. We can do that one of 2 ways, cooling blankets or Tylenol. These patients do not, and I repeat, do not get any medications that contain salicylates or aspirin. Aspirin is a no-go for these patients. Aspirin is a no-go. They can also have high blood pressure, high heart rate, high respiratory rate. We got to get this fixed. So adenosine for the SVT can happen. Well, we also can use what's called anti-thyroid medications. There's a couple of different ones that I'm going to tell you about. Anti-thyroid medications. First one being Tapazole. Thing to know about Tapazole is it cannot be used in pregnancy. So if you've got a pregnant patient that develops a thyroid storm, they cannot take Tapazole. It is tetragenic to the baby. All right, they can also use PTU. PTU actually is okay to be used in pregnant patients, but the first trimester only. Other treatment options that you can use, iodine, because it inhibits the uptake of the T3 and T4. They can also use a medication called Lugol's solution. L-U-G-O-L-S, Lugol's solution. That helps to block the secretion. We can also use beta blockers. What do beta blockers do?
Slow the heart rate.
Slow the heart rate, slow the blood pressure. Who can we not give beta blockers to? Asthma patients. Sam, you were so smart. I knew I liked you. Yeah, girl. Asthma patients. Beta blockers have to be used in caution with patients who have asthma, okay? Another thing is they might need steroids. Now this can be something like dexamethasone, because that's going to help to hopefully decrease the immune system, which is going to decrease that inflammatory response that's going on. You have this big storm in the body, we got to kind of chill it out a little bit, okay? So the Lugol solution, or the iodine, the Tapazole, the PTU, all those are going to go in and tell the thyroid, hey, you need to chill it out. You are causing all this ruckus, and we got to calm it down. The beta blockers and the adenosine are going to help, as well as the dexamethasone, are going to help with the side effects that are occurring. That inflammatory response, that hypertension, that tachycardia. And then remember we said Tylenol for the fever. Nothing with, what in it? Aspirin. Nothing with aspirin in it. We're going to be monitoring these patients really closely. As their nurse, cooling blankets are going to help. Trying to cut down on stimulants. Lower the lights. Shut out the visitors. Anything that can stimulate that patient, we want to try to cut it out. So no stimulants. Also going to monitor their vital signs, monitor their EKG. All right, we good with thyroid? We ready to move on? Gotta slide across the floor. All right, let's talk about the pancreas. Your pancreas is responsible for releasing alpha cells and beta cells. What do beta cells control with relation to diabetes? Insulin, thank you. It controls insulin. Alpha cells control glucagon. They work together in balance to keep your blood sugar in balance. We need a healthy supply of insulin and a healthy supply of glucagon in order to keep your blood sugar in balance. Now, when it becomes out of balance and we get into an endocrine crisis, that's when the problems start, okay? So let's start with DKA. DKA primarily affects type 1 diabetics. So it primarily affects your type 1. It also happens suddenly. Usually comes on pretty quickly. Most oftentimes triggered by either patients not taking their insulin, because remember your type 1 diabetics are usually insulin dependent, or excuse me, not usually, are insulin dependent diabetics. So either A, they didn't take their insulin, B, they're under a huge amount of stress, like nursing school. 2, they have some type of infection. primarily happens when their blood glucose level gets above 300. Some resources will say 250, some will say 300. I'm not going to ask you that on the test. It's just something you need to know. Your blood sugar's high. Do these patients produce enough insulin? Do they produce insulin at all? No, they don't. So if I'm not getting the insulin that I need, my blood sugar's getting high, my body starts freaking out. It starts freaking out saying, I gotta have sugar somewhere. There's sugar somewhere, I need to find it, I need to find it. Even though their blood sugar's high, they're starting to freak out. When they start freaking out, then we have what's called fat breakdown. It starts to break down the fat to use for energy. When that happens, we release ketones. Our ketones are what is responsible for our DKA patients having that fruity odor type breath. You ever smelled juicy fruit gum? Mm-hmm. You ever smelled a really bad alcoholic? It smells the same. It really does. I'm not joking. That fruity odor comes from the ketosis, the fat breakdown releasing the ketones. That's where you get the fruity odor from. These patients are also going to have Kussmaul respirations. What is a Kussmaul respiration? Short, fast, shallow. Really breathing heavy and fast. Why does our body do that? To blow off what? CO2. Why is that?
Because
We got lots of acid on board. Well, our body has to compensate, okay? We'll have acidosis. So our body's way of compensating is the Kussmaul respirations to help blow off some of that CO2. Because remember back to your ABGs, your lungs are responsible for your CO2. So your lungs are usually the first thing that's going to start kicking in when compensation occurs. So Kussmaul respirations happen because of the ketosis, which leads to the acidosis. So we're going to hopefully start blowing off some of that CO2 to try to put us back in balance. These patients will also have polyuria, polydipsia, polyphagia, just like a normal diabetic patient does. Polyuria, polydipsia, polyphagia. They are also severely dehydrated. Now, when I say acidosis, what type of acidosis am I talking about? Respiratory or metabolic?
Metabolic.
It's metabolic acidosis. All right. Put a pin in DKA and let's move to HHS real quick. HHS affects, or it's hyperosmolar syndrome. It can also be seen in some resources as HHNK, or hyperosmolar non-ketotic syndrome. This primarily affects type 2 diabetics. Do they produce insulin?
Yes.
But not enough, right? They produce it, but not enough. So if they still produce insulin, do I need to break down fat and release ketones? No, I do not. Someone with HHS, there is absolutely no ketone issues, which means there's no acidosis. So they don't have the fruity odor of the breath or the Kussmaul respirations because there's no compensation taking place because there's no ketosis, thus no acidosis. This also occurs gradually and happens when their blood glucose level usually gets above 600. They are also really dehydrated. That's really the only similarity in the two, is that they're both dehydrated. Trigger for that's also going to be infection, illness, stress. Now, I told you to put a pin in DKA. Reason being is because we treat them primarily the same. So whether they have DKA or they have HHS, we're going to start treatment the same. The first thing that we're going to have to do is IV fluids, because they are severely dehydrated. What type of IV fluids do you think we're going to start with? What's usually used for acute dehydration?
Normal.
Normal saline. So we're going to use normal saline. When we're doing IV fluids, usually we start with about 20 milliliters per kilogram for the first hour-ish. They're severely dehydrated. They need a lot of fluids. While we're giving these fluids, we're waiting on their labs to come back. Now, I say this to say that I've been a nurse for 20 years. I can't tell you how many patients with DKA I've seen. I've only ever seen a couple with HHS, but DKA is pretty common. You see it a lot, especially in your juvenile diabetics, your kids. I can't tell you the amount of times I've had people come in, they're in DKA, we start an IV, we give them fluids, and we automatically start bolusing them with insulin. That really didn't come to people's brains until in the last few years, because so many people with DKA have died because of cerebral edema. Because the first thing that they get when they get to the ER is they get an IV, they get a bunch of fluids, we're shooting them up with insulin and shooting them up with sodium bicarb. All that stuff together causes massive cerebral edema. All the extra fluid shifting, massive cerebral edema, we wind up killing these people. So, good rule of thumb to know, you've got someone, whether they're in DKA or HHS, start an IV, start giving them fluids. A lot of protocols and stuff have changed, especially for our pediatric patients. I had a very dear friend of mine whose son died from DKA, and he got to the ER, got insulin bolus, got put on an insulin drip, they gave him some bicarb. Before the helicopter even got there to get him, to take him to Atlanta, he wound up having severe cerebral edema and passed away like a day later. He was 8. It was really sad. So IV fluids, nothing else until you get your lab work back. When I say lab work, I'm really looking at my complete metabolic panel. Which electrolyte do you think I'm really concerned about? Potassium. I am really wanting to know what my potassium level is. That is extremely important. Why does that matter?
They work together. If one's high, the other one's low.
Yep, that is true. But why does it matter in a DKA patient? Because of the insulin. What do we do for patients who have hyperkalemia?
We give them insulin.
We give them insulin, because what's the insulin do? Pushes that potassium back into that cell. So I need to know what my potassium level is before I start bolusing these people with insulin. You'll see how that can be a problem? Most definitely. So IV fluids first, and wait on that potassium level. Excuse me. If your potassium level is fine, your physician might go ahead and order a bolus of insulin and an insulin drip. Usually your insulin drip is going to be 0.1 units per kilogram per hour. It's traditionally where it starts. And then they'll recheck a blood sugar every 15 minutes. Someone on an insulin drip does have to be in the ICU because it is a titrated drip. Y'all talk about titrated drips, right? It's a titrated drip, so we've got to constantly titrate it based on what their blood sugar is. But I want to decrease that blood sugar slowly. If I decrease it too fast, I cause massive fluid shifting leading to cerebral edema. Now, other treatment forms that I can use is sodium bicarb. Now, sodium bicarb is only going to be for patients who have DKA. Why is that?
Because they're acidotic.
Because they're acidotic. Sodium bicarb is going to help neutralize that acid. HHS patients don't have any acidosis, so they really wouldn't benefit with sodium bicarb. That's really going to be your only outlier. So IV fluids, watch the potassium level. Once it's back and it's okay, doctor will order an IV bolus of IV insulin, and the patient will be on an insulin drip. Now, what type of insulin is used IV? Regular insulin, or it has a big R on it. Your regular insulin is your only insulin you can give IV. Another thing that they'll look at, blood level wise, that we don't have listed over here, is an anion gap. Usually if it's between 10 and 12 or higher, that means that they are in what we call DKA. Actually, let me move that over here. I apologize, guys. Let me move that over here. An anion gap between 10 and 12 usually signals that they have DKA. So what an anion gap is it takes the anions and the cations, so your positive electrolytes and your negative electrolytes, and it sees how they fall together, and they see what the gap is in between, and it's given a number.
If you're in the positive.
You're in the positive, we got a problem, a big positive. Usually anything greater than 10 signals that they have DKA. I didn't expect you to know how to calculate that. That's something you might learn later. It's not really entry-level nursing. But do know that if you have a high anion gap around 10 or 12, that does signal that your patient has DKA versus HHS. Because if they're unsure which one the patient has, they'll look at an anion gap. It will not be elevated like this in a patient with HHS, just in a patient with DKA. These patients will also gradually change from normal saline IV fluids, usually to a hypotonic solution, like D5 half normal saline. So D5 half normal saline. Well, now that's got a 5 in it, and I thought 5s were hypertonic. What's going to happen to my body when I put this in? What's going to happen to this dextrose?
It's gonna be metabolized.
It's going to be metabolized, and then all I'm left with is half normal saline, or 0.45%. If I metabolize the D5, I'm left with half normal saline. Where does half normal saline fall over there? Hypotonic solution. They will do this when the patient is still in PO. A patient in DKA or HHS will not be allowed to eat until their blood sugars get under control. So they'll be NPO. So if a patient is NPO for 24 hours or longer, they'll switch them from normal saline to D5 half normal saline, so that their body still has some dextrose to metabolize. Your brain needs a constant supply of fluid, glucose, and blood. If we don't, then we're gonna have issues. We're gonna have altered mental status or confusion. So after about 24 hours, our body's gotta switch to the D5 half normal so that we've got something to metabolize, so that we can give our brain a little bit of glucose so it doesn't freak out on us, okay?
How do they give the sodium bicarb?
It's usually given IV push. So you know those big vials of sodium bicarb, like they're huge. They're like the big ones that you'll see in the crash carts, that's what they'll give.
I've given it, but it was through a central line.
Mm-hmm.
I was told it'd be pretty harsh.
Sodium bicarb, not really. Now, I know dextrose is. Like if you give dextrose through a central line, or any IV really, because it's really thick, it can be pretty harsh on the vessels. Bicarb's not usually that harsh. If you can give it in a central line, better, because it's a lot to push at one time. But it's not usually harsh on the vessels. All right, make sure I want to say anything else. Oh, what happens if my potassium level drops? My potassium level's okay. I'm on an insulin drip. I'm going to keep a check on this potassium, because if it starts to get too low, I've got to supplement it, because they need the insulin to get their blood sugar down. But if I'm given a bunch of insulin, I'm going to lower that potassium level. So they might have to get some type of potassium supplements, whether it be, you know, the micro K tablets, or they might have to get IV potassium. Remember, IV potassium is very irritating to the vessels. So you definitely keep an eye on that potassium level. You're also monitoring for any signs of cerebral edema. How do I know my patient has cerebral edema?
Level of consciousness. Your level of consciousness.
Right. Think about, y'all talked about increased intracranial pressure yet?
Mhm.
All the signs and symptoms of increased intracranial pressure is exactly what you'll see in a patient with cerebral edema. So while these are vastly different, we're kind of treating them about the same way. The only real difference is the bicarb. Everybody good with that? Got two more. Two more and then we're done. All right, so let's talk about the last key hormone that we've got down there is your ACTH, your adrenocorticotropic hormone. That is responsible for your adrenal glands. Your adrenal glands sit on top of your kidneys. Now, they are responsible for releasing hormones within the body. A couple of different hormones. Your adrenal medulla, for example, is responsible for your catecholamines. Catecholamines being your epinephrine, your dopamine, and your norepinephrine. That's all your fight or flight stuff, okay? When you've got a fight or flight moment in your body, that's what's happening. Your adrenal medulla is shoving out all this stuff, all these hormones to either tell you to run and get the heck out of Dodge or stay and fight. One of the two. It also tells your adrenal cortex to release hormones. These hormones are going to play a part in your Addisons and Cushings. Now, epinephrine, norepinephrine, dopamine, fight or flight, yay. Something to know that that does happen because that is part of the adrenal gland, but it's not going to be something that we talk about with Cushing's and Addisons. Instead, with your adrenal cortex, we're worried about sugar, salt, and sex. The 3 S's. Sugar, salt, and sex. I either got too much or not enough. So your sugar hormones, that's going to be like your glucocorticoids. Your glucocorticoids. That's going to be your cortisol, which is responsible for your blood sugar, is responsible for your metabolism, helps to regulate your blood sugar, helps with your immune response. Your salt hormone, messed up my A. Your salt hormone, that is your mineral corticoids. Mineral corticoids. That's like your aldosterone. That's going to regulate your electrolytes and your volume balance, you know, holding on to water and sodium or letting it go. Also regulates your potassium. I'm holding on to sodium and water, I'm spilling out my potassium, and vice versa. Your sex hormones are also known as your androgens. Your androgens. They control your sex drive. The bad thing about that is, it doesn't matter how much sex hormones you have or how little you have, they pretty much do the same thing. You got too much or too little, it's not a good thing. All right, so let's talk about Cushing's. Cushing's, I have way too much. I have way too much sugar, way too much salt hormones, and way too many sex hormones. I am a Cushing because I am nice and plump and full of all these wonderful hormones. And it sounds like a great idea, right? Got a good bit of sugar, a good bit of salt, a good bit of sex hormones. Doesn't sound like a bad thing, but technically it is. So your sugar hormones, if I've got too many of those, what do you think is going to happen to my blood sugar? I'm going to increase my blood sugar. So I'm increasing my blood glucose levels. I've got a lot of blood glucose levels going on. I'm also going to delay my immune response, delay wound healing. So increasing my blood sugar, delayed wound healing, delayed immune response. I'm also going to have holding on to a bunch of salt hormones. I got a lot of extra salt hormones. So what do you think happens to my sodium level? It's going to increase. My sodium level increases. What do you think happens to my potassium level? It's going to drop. Another weird thing that this salt hormone does is it messes with my calcium. Okay, we don't mess with calcium. That's a no-no. But it's going to mess with my calcium. It's going to lower my calcium levels too. It's also going to increase my blood pressure. Now, having a lot of sex hormones sounds like it might be a good thing, right? It's not. Instead, it's going to decrease your sex drive and give you problems with ED. Not a good thing. Now, how does this happen? How does this happen?
Cushing's disease,
Uh-huh.
it causes, it's a decrease in your
You're
thyroid.
supposed to say tumor.
Oh.
I've been saying tumor all night long. Tumor. Tumor, tumor, tumor. Okay, usually the reason that you're going to have issues with your sugar, salt, and sex hormones, whether you've got too much or too little, most oftentimes is a tumor.
Okay, my bad.
That's okay. Fully relied on the tumor thing, but that's okay. That's my fault. It's no biggie. This can also happen it's more common in your women than it is your men, usually a 4-to-1 ratio. Very common in your women. It's also very common in people who are on cortisol type hormone replacements. Can also happen to patients like asthma patients and rheumatoid arthritis patients that take cortisol type drugs or those glucocorticoid steroids. And if you didn't know, all these are steroids. And not the good kind that make you get muscles. Which really there's no good kind of steroid, just so we're clear. But tumor, also small cell lung cancer is also another one that can cause Cushing's disease. So these patients, what are they going to look like?
Brown.
Swollen.
Round. I like
Hairy.
it. Swollen, round, hairy, the buffalo hump, the moon face, the mustache, the striae on the stomach, big old buffalo hump on their back. They're very fragile skin. So how do we fix it? Well, we got to fix the cause. What caused it? Was it small cell lung cancer? Was it a tumor? What caused it? Was it because their medication? They're taking too much cortisol? How do we fix it? By fixing the cause. What else can we do with it? Well, these patients can actually get chemo or radiation if it's a tumor. That can help. Or we can also go in and just take out the adrenal gland. You know, with hyperthyroidism, what do we do to the thyroid? Kill it or take it out. Same thing with your adrenal glands. Kill it or take it out. It's not really a great drug to kill it, so they'd have to go in there and do what's called an adrenalectomy and take your adrenal glands out. One thing that's really important with your Cushing's patients is while you're working on treatments, your diet is very important. This is probably the only patient we've been talking about with diet. So your diet is very important. What do they need a diet low in?
Sodium,
High in?
calcium,
What about fluid?
and
Hmm?
I'm gonna say plenty of it. Supposed to drink, I think.
What does salt follow?
Round, so
Around.
it means you're, have too much.
I like it. They got too much, so we're gonna maybe do a fluid restriction, right? Think about fluid restriction. So a diet low in sodium, low in fluids, high in calcium. They also need a diet high in protein. Why do you think they need a diet high in protein?
To help with wound healing.
Helps with wound healing. Remember, they've got too much sugar hormone also, so we're also going to be keeping a check on that blood glucose level, and they might need a diabetic diet as well. We might have to put the grams of carbs down. That's going to really depend on what their blood sugar is looking like. but protein's gonna help with wound healing. We want to make sure that these people avoid sick people at all costs. Try to avoid sick people. So visitors, most oftentimes these patients are gonna be on isolation, usually like a reverse isolation. You remember talking about neutropenic isolation or reverse isolations? Try to avoid sick people, avoid infection. Really monitor their labs. So monitor their complete metabolic panel, monitoring their vital signs, monitoring their glucose level. I'll tell you right now, nobody really cares about the sex hormones. There's not really anything that we're gonna do about that. We gotta save your life. We don't care if you can get it to working or not. They might also need a psych consult due to their body image. If you look up a patient with Cushing's, that poor lady, I swear it's the same lady from like 50 years ago. Look it up on your phone. I see you, Sam. Pull it up. You see what I'm talking about. I swear they've used that same lady's picture for years. I feel really bad for her. Like, she is like all out in the open. And she looked pitiful.
I have a man.
You have a man with Cushing's? Are you sure it's a man?
I mean,
Oh, it's cool.
no.
Is it this girl?
I was completely naked.
Mm-mm. I can't really see that very well. It is small. It's a lady with short brown curly hair.
This one?
Yes, that lady.
Oh, okay.
They've used that picture forever. I swear I saw that picture when I was in school a million years ago. But she's got truncal edema, buffalo hump, moon face, facial hair, all the things. So a psych consult's not a bad idea to help with body image. Skincare is also very important because if we've got a high blood glucose level, then we're going to have poor or delayed wound healing, and we really got to worry about our skin. Now, that's Cushing's. Addison's. Addison's, we ain't got none. We ain't got no sugar, no salt, and no sex, okay? We got to add it in. Over here, we've got a Cushing of hormones. Over here, we got to add these hormones in, okay? So if I have no sugar hormones, what's going to happen to my blood glucose level? It's going to go down, so I really got to be watching out for hypoglycemia, right? What's going to happen to my sodium if I ain't got no salt hormones? Down. Now, if I've got low sodium, what happens to my potassium? It goes up. And ironically enough, my calcium's also going to go up. No sex hormones? Well, they have no drive. So they have a decrease in their drive or a decrease in their libido. These patients can also have the sex hormones, the decrease in the sex hormones. They can have a bronze skin and hirsutism, or abnormal hair growth, rather, is a better word. This happens when I don't have a good secretion of hormones. So remember with your Cushing's patients, I have an overabundance of hormones. If I have an adrenalectomy and I cut the adrenal glands off, I go to here. Same principle as with your thyroid. I move from hyperthyroid to hypo. Same thing with Addison's and Cushing's. I take my adrenal glands off, I'm going to wind up in Addison's. So now I got to add it in. How do I add it in? These people are going to be on a lifelong supply of steroids. Prednisone or prednisolone is probably the most common one that you'll see. Most oftentimes this is caused either from treatment of Cushing's, or it could be on its own thing. It could be a tumor. Tuberculosis infections actually block your cortisol, so it can actually cut it out altogether. Cortisol is a big component of your steroids. So if we cut it out, then we're going to be left with Addison's, no steroids. So these people are going to be weak, blood sugar's gonna be low, sodium level's gonna be low, potassium and calcium are gonna be high. Really gotta watch those heart rhythms. Another thing that you can see is an Addisonian crisis. Now, requires immediate intervention, just like your thyroid storm. It requires immediate intervention. Reason being is it can take all this right here and overdrive. More so concerned with your blood glucose, your sodium, your potassium, and your calcium. Same thing as you would see with your patients with myxedema coma, how everything just slowed way down. Thyroid storm, everything got really fast pretty quickly. Addisonian crisis, usually the number one reason this happens is because people abruptly stop their steroid intake. How many of you here have ever taken a steroid dose pack? You notice how it goes from like 7 pills to 6 pills to 5 pills. That's because steroids, you have to taper the dosage. If you automatically cut it off cold turkey, you can throw your body into an Addisonian crisis. And you've never had an adrenal problem before. Which is why it's very important when you take a steroid dose pack that you take it just like it's labeled. You don't take, 6 pills every day and then stop taking 6 pills. You have to take it and taper it off. Because a sudden stop in steroid usage will cause your adrenal glands to freak out and they'll just stop producing everything. So they'll go into an Addisonian crisis. How do we fix that? IV steroids. Now, Addison's disease altogether, remember your diet we talked about with Cushing's? We need a diet high in sodium. They're fine to get as many fluids as they want. But a diet low in potassium and low in calcium. Also, plenty of protein and carbs is helpful. Why do you need protein and carbs? I'm not producing enough sugar hormones. I gotta have those protein and carbs to keep my blood sugar in check. As a nurse, we're gonna make sure that we're monitoring all these electrolytes. We're monitoring their vital signs, their EKGs. Any questions about Addison's or Cushing's or Addisonian crisis? Any question about anything that we have covered on this board tonight? Maybe tomorrow?
Yeah.
That's okay. I'm gonna put my email up here real quick. I use my A number email because I got married 3 years ago, and when they changed all the emails, sometimes my other email works, sometimes it doesn't. So A02037723 at alabama.edu. I'm also in your Canvas course. You can also email me from there if you have